Good morning. This is the recorded lecture for Chapter 9. We're going to be talking about therapeutic communication. Um, so you do have a little cheat sheet as well that I gave you. I've uploaded in the course on how, and we're going to be discussing that in class. However, as far as therapeutic communication, we know that it's patient-centered, it's goal-directed, and it's scientifically based. Patient-centered meaning that the refer to the patient as a partner in cases where values, preferences, and needs are respected, meaning we respect the needs of those clients and their values. Therapeutic communication is critical to the formation of patient centered therapeutic relationships. So, saying the wrong thing, making mistakes, helps us to find more useful and effective ways of helping our individuals reach their goals. So, again, we have to communicate therapeutically. As far as the benefits to the patient feels safer, they feel protected, they're more satisfied with their care when we communicate therapeutically. The increase in recovery rates are known of done. The recovery rate increases significantly when we communicate therapeutically, and also the clients they adhere to treatment regimen, their treatment if we convey information that is therapeutic, clear, and concise. Also, as far as the transactional model, I'm sorry, the model of communication, encoding, decoding. When we interact with clients, we develop messages and we send those messages. Sometimes those messages are decoded. Then the client may have to determine the meaning of the message received from someone from the sender. The context of the message influences the interaction as well. How we send that message, how those clients perceive those messages. Environment. If there's a lot of noise, the noise also disturbs the messages flow and serves as a barrier for those clients as towards interaction. So loud noises, and then sometimes the clients are they're physiologically illness may also impact communication. So again, we look at the communicator, the message, the channel, how we transmit that, how we then the feedback, and then again, like I said, encoding and decoding, and then context of the message, and then the environment in which those messages are conveyed. So again, you're talking loud, or the client there's loud noise, or the client has hearing deficit. That could also be a barrier on how they perceive those messages. Let's look at a case study. You are a new nurse in the psych ward for adolescent. Noah is your first patient. He is depressed and has fresh cuts on his wrist, which is why his mother has had him admitted. While taking his pulse, you see that Noah also has a number of older scars on his arm. When he sees you looking at them, he shakes his head and whispers, "Yea, well, it's just gonna keep on happening." So he's telling you something. So that tells you that um, he has done it before, and he's telling you that it's going to keep on happening. So as we look at this question, so Noah whispers a statement, yes, well, it's just going to keep on happening. Does not involve which of the following. So what is he talking about? So what about feedback? So feedback is provided by the person receiving Noah's message after interpreting the response. This is what the nurse will do in response to Noah's statement. So again, which implies a desire to understand, perhaps, and help. Nor is the sender and the stimulus. Here is his needs to communicate with others. So he's telling you, oh yes, it's going to keep on happening again. So this is a time where, as the sender, he's telling us something. He's needing help. So he sends this message through auditory channels. You hear it, what he's saying. But he's also whispering. So again, the nurse, you heard, hopefully you heard what he said. If you didn't, it's okay. We're going to talk about some communication techniques. If you didn't understand or you didn't hear, how you can get Noah to open up to you. But basically what he said, like I said, he is so as far as the feedback, we as the nurse, we should be the one is provided by the person receiving the message. So we need to get feedback. We need to get clarity from Noah based on the statement that he has made. So he gave the message, and so we need to, okay, what is he trying to convey to us? What is an inappropriate response to Norris Whisper's statement of yes, well, yay, well, it's just going to happen again? What do you think is inappropriate? Will it be report this statement to his parents, report this statement to your supervisor, tell no you're willing to listen if he wants to talk about it. So you're getting him to open up. So he implies that he's needing help, he's wanting help. You wouldn't tell Noah you're willing to. I'm sorry, you wouldn't tell him that you wouldn't ignore the statement. Rather, the patient is a vulnerable state, is in a vulnerable state, and is risky to say the wrong thing. So again, you want to let Noah know, tell him, I'm here out to listen. I'm willing to listen if he wants to talk about it. But just we're going to talk about some ways that you can solicit more information from Noah at this point. So Noah's statement implies a desire to be understood and perhaps help. He's seeking help. He sends his message through a whisper statement meant only for the nurse to hear. Because he didn't, if he wanted his parents to hear, because he would have shouted out if he wanted someone else to hear. So he wanted to just the nurse to hear. Okay, although, so even if the nurse says the wrong thing, a response is needed to convey the sense of safety, make sure he's safe, and then, he can let him know that he can express his needs to you. Because if you don't listen to him or shut him down, or like, I'm gonna, let me just get somebody else in to see what you're saying, he may or may not um, convey that information again. So he's open, it's expressing he's open, you know, and when I'm sorry, we need to let him know that we are open to his expression, with acceptance of his statement that he's made. And we care, we concerned about it, okay? So again, these are some factors that could affect communication. One could be, I'm sorry, depression could factor communication, cognition, client mental status, their language, their culture, of course, environment, like I said, the setting as well. Also the level of equality within the relationship. Now, again, a client he must or she must trust you. They must trust you to convey information to you. Okay. And I don't think I have it on the slide, but when we talk about as far as Pavlov's interpersonal theory, this is a theorist that his guiding principles of communication, clarity. Like I said, we got to make sure we understand what the message is, get a clarification, and continuity. Um, Again, we got to make sure that we be a good listener. You know, so Pavlov's encouraged non-directive listening, which allows that nurse to provide reflective and non-judgmental feedback. You can't be judgmental. So again, clarifying what the client said, and then once they tell you how they feel, we can't be judgmental. Okay, that's based on Pavlov's theory. So again, like I said, verbal communication is a biggie also. So verbal communication, we've got to all words. These are words a person speaks. We know that. Again, when they speak, when they communicate, we got to take in consider their belief and their value, their perception, their meaning, how they perceive, what their perception of what they are saying. I may tell you something, but you don't know what my perception are unless you ask or I share that with you, okay? Because we may be perceiving that message differently. So again, you want to get patient centered. Verbal communication can be conveyed as interesting and understanding. Can convey. I'm sorry, interested and understanding. Insults and judgment. Like I said, we can't be judgmental. Clear. It could be clear or it could be conflicting. It could be honest communication or it could be distorted. So again, you can't deny what a client is saying. But if somebody telling you that, yes, I have a laceration to my arm, and then you don't see that laceration, so again, this is distorted. So you want to know, they may in their mind, consciously, in their mind, they may be having some, mental concerns going on. So they may think that they have a laceration to their arm. So you don't, well, that's not a cut on your arm, just say, I don't see, can you explain to me, or something like that. So you don't want to be confrontational with these clients. Again, you want to listen to what they're saying. Like I said, the perception of what they think is a laceration, what you actually see, could be totally different. As far as nonverbal communication, again, the tone of voice. Sometimes clients may have a flat affect. They may not say anything. They may just sit and look at you. So again, emphasis on certain words. They may emphasize certain, then they may not. Their physical appearance is a way of non-communication. Facial expression. Sometimes people frown, and if when we're doing pain scale, sometimes if a patient is nonverbal, they may have a frown, a grunt, or something like that. So facial expression, body posture. Again, sometimes clients may ball their fist up. They may ignore you. They may turn their back to you. They eye contact based on a client's culture. They may or may not, you know, um, do eye contact. So it may be based on their culture. So we have to respect that as well. And hand gesture, like I said, they may thrash in their hands by throwing their hands, not saying anything. Sometimes just, just kind of waving your way. So these are nonverbal forms of communication. And we need to take note to those because sometimes clients, if they don't say something, those may be those clients that are very, very, dangerous. They could be. Interaction of verbal and nonverbal communication. Messages can appear to be one thing when it's in fact another. Always get an understanding of what is that message is, what that client is trying to say. People are often less aware of their nonverbal messages and behavior. Sometimes people roll their eyes. They fix their eyes on you. So verbal messages can be called content, while nonverbal is behavior, non-behavior, nonverbal behavior is the process. Double blind messages that could be contradictory, usually given by a person in power. So again, you have those double bind messages, mutually contradictory. I don't know what is being said because it's contradictory. They may say one thing this minute and say something else, or they may say something and do something different. So again, just keep that in mind. This is another case study. As you prepare for the initial interview with the 15-year-old Noah, you learn that he has a history of cutting himself. His parents are separated and are getting a divorce. His father has left and Noah is living with his mother. Noah has been smoking for about a year and a half, and his mother suspects that he has come home smelling marijuana twice now. All three behaviors were ongoing before the father left. Okay, so this is again, this is some history here. So based on the scenario, which behavior from Noah would be considered as double bind message? He winks at you and say, does any of these nurses date 15-year-olds? He puts his head in his hand and shakes it and snaps, I don't want to do this, just get me out of here. He sneers at you and almost purrs as he says, oh, yes, I will tell you anything that you want to know. Of course, I will. So again, here, and then he cries and shakes, jiggling one leg, and he says softly, please, let's just not talk about dad, okay? God, please. So again, C is the correct answer. A double bind message, mutually contradictory message given by a person in power or attempting to gain power. In example C, Noah he's in a frightened, uncomfortable position and attempts to gain or maintain some control or power. So, oh yes, I would tell you anything you want to know. Of course I will. You, the nurse, want information from him. You want his cooperation, but he doesn't want to give it to you. So his nonverbal language, sneering, rocking, mocking, and so it contradicts his verbal message. So again, so C would be the correct answer here. So it's double bind. So you don't really know what he's thinking for the most part. Therapeutic communication techniques, like I said, sometimes it's just good to be silent, just to be a good listener, active listener. Clarifying techniques, and we're going to be talking about some of these techniques this afternoon. Question, open-ended question, closed-ended question, projective, and the miracle question. Okay, so these are therapeutic techniques. And so non-therapeutic techniques, excessive questioning. You don't keep asking the same thing over and over again. If client tell you they don't want to be bothered, or you keep asking the same thing, they're going to get very agitated. Giving approval or disapproval. Like I said, it implies that the nurse has a right to pass judgment. So that's offering or giving disapproval. And we don't have that right. And then asking the why question. Asking the why question, again, that could be very intimidating. Why did you do that? Why did you smoke? Why do you smoke? So that's a no-no. And then as far as the next scenario here or audience question, let's just look at this. So Noah has made it clear he doesn't want to talk about his dad, But the truth is, as the interview proceeds, he becomes anxious and tries to evade all question about why he's there. Which type of communication might be appropriate right now for Noah? What do you think? Stop questioning so much and just give him some time, give him some good advice so he'll trust you. So giving advice, offering advice, I think you should. This is non-therapeutic. In my opinion, that's non-therapeutic. Express honest disapproval of his resistance. We just said we often disapproval or approval. That's good. That's all. That's non-therapeutic. Ask him point blank, why is he evading you? That's the why question. We don't want to ask why. Then you're going to ask a miracle question. A miracle question is a goal setting question that helps the patient to see what the future will look like if a particular problem were to vanish. While Norris is anxious about saying anything about specific about his trouble, what's troubling him now, he may be able to talk about what he might wish for. So this very basic question often gets to the source of the most important issue. So this is what we want to ask. What's going to get us to the issue here. So we're going to ask a miracle question. Again, culture and consideration. Uh, again, I can't stress that enough. I talked about eye contact, communication style. We must know. We again, like I said, culture norm dictate a person's comfort or lack of comfort with direct eye contact. We have to um, respect that. And perception of touch. That may be a culture. Touching may seem as healing or supportive, but it also can be as aggressive, intrusive, or it can be sexually inviting of others based on their culture. So again, be very conscientious when you touching someone. So again, so culture filters from could be bias, or a form of bias or it could be a form of prejudice. So again, be very conscientious. You don't want to touch someone based, on that culture because they can take it very offensive or aggressive. And I've known people to press charges, well, I just touched her on her shoulder as a form of, no, we don't touch. Okay. Information communication technologies. Again, this is where we use electronic information. Y'all already know that. It's sometimes to help with our communication, we have inactive, live interactive mechanism, a way to track data. Again, to help with communication techniques based on culture. Again, we may have some translators, kiosks, and things of that sort. So again, we definitely I see those coming up in a lot of facilities to help with translation based on culture. Telehealth or telemedicine. It's how on the rise to clients that are living in underserved areas or clients that are not just underserved areas, but this is a good way of communicating with those clients that have a stigma of coming into the clinic for help or living in rural areas where they don't have access to help like psychiatry, phone consultation, also counseling, image transmission, and then interactive video session. So these are all some good forms of communication. We're just trying to reach our clients. Mobile application, another information technology. These mobile applications help to monitor, to diagnose, treat, and communicate with clients. Mobile phones are used at an all-time rate now high. There are many apps out there that are available. Also, the SAMHSA is a free app also for suicidal prevention, bullying prevention, and under drinking prevention. So these are all apps that are available for those clients. We're trying to reach those clients. We're trying to communicate them to get them into treatment. Okay. These are some concerns, however, privacy and confidentiality. We know that technology can be compromise, and then lack of efficiency and safety, liability issues. These are some concerns with technology. And so, a lot of more research is needed to evaluate the risk and benefits. Okay. There are some professional and ethical guidelines needed also with with technology communication. However, it's best to reach a client some way than not meet them at all, meet their needs at all. But again, there are some could be some legalities or legal issues, dilemmas as it relates to communication. Let's talk about as we getting ready to interview our clients. We're talking about communication, therapeutic and non-therapeutic. We got to set the pace. Some key points as far as we setting the pace. Seating arrangement uh, can be face to face with the table between the clients. It could be no table. You can set it at an angle. So some people believe that face to face suggests that potential power that there serves as a barrier. However, face-to-face discussion does not facilitate the best reading of nonverbal. So again, it just depends on the client and where you are. When we're doing face-to-face, like I said, they may like, well, why we got to have this desk between us. Now, again, could be due to the arrangements of a room or the area that you're in. But all of these are taken into consideration. The pace of the interview, the seating, and the setting. The setting also, is it structured? We talked that milieu setting. Is it structured? And then also introduction. You've got to introduce yourself. Then you got to initiate the interview. This is I gave you an example of the process recording. Again, this is how you're gonna. The purpose of this process recording or the interview. Um, I'm sorry, a guideline that's going to help you set the pace. You're going to establish that rapport with the client, and then how you can initiate the conversation, what was said, and you're going to document that on your process recording sheet. So when you're doing the interview, these are some things that you do want to avoid. You don't want to argue. You don't want to minimize or challenge the client. Give false assurance. If you tell them you're going to be back on a certain date or time, you need to um, let them know that. So as we talked about the phases of care, we talked about the orientation phase. So again, the termination phase. Let them know that I will only be here for X amount of time or whatever the case. Interrupting or speculate. Let the client speak. Don't speculate. Don't take those sentences out their mouth, words out of their mouth. Probing into sensitive areas the patient doesn't want to discuss. If a client does not want to discuss something, don't probe. Actively let them actively communicate that to you. So don't probe. Don't try to sell self the patient. Don't trying to sell the patient on accepting treatment. Explain to them the treatment. Don't try to force them to accept treatment. If they say I don't want this treatment, I don't want this medication, don't force it on them. Joining in attack with patient launching on others. Say for instance, if one client, if they get into an argument, you don't want to get into and take sides with another patient. Okay, so participating in criticizing other staff members. If a client tell you, well, Nurse Jones came in, they were very rude to me, they were dirty, whatever the case may be, you don't want to engage in that conversation, okay? You don't ever want to do that. These are the behaviors that support counseling, attending behaviors, kinetic communication. It's a type of nonverbal communication made by the body. Like I said, this is a form of what? Facial expression, body posture, gestures. These are all kinetic types of communication. And then it's I'm sorry, the study of personal space. Like I said, again, you've got to give a client their space. And this is based on what the literature say. Social distance is anywhere from 4 to 12 feet. Public is 12 feet or more. And then intimate distance is, you don't have to remember all this. But again, just remember, when you're counseling a client, you got to make sure you give them their space. And again, I can't stress the importance of eye contact, how important it is that it varies from culture to culture. Clinical supervision and debriefing, communication, interviewing are acquired skills. We don't expect you to go in and to know all of these skills, but you do need to know the basics, okay? Uh, so again, debriefing, when we talk about debriefing, we've had a situation. We want to know what did we do right, what did we do wrong, and then sometimes debriefing constitute policy changes, okay? It also fosters professional growth and minimize development of non-therapeutic nurse-client relationship. So again, we want after we've done our counseling or supervision or whatever. Uh, Again, what did we do right? What did we do wrong? Again, so debriefing is very, very important. And I kind of got a little bit ahead when I talked about the process recording here. And again, like I said, go back to the sample that I gave you. It's a written record of segments of the nurse client session that reflect as closely as possible verbal and nonverbal of both the client and the nurse. Now, we don't expect you to remember everything, so you when you in the clinical setting, we want you to remember as much as you can and document it as soon as you can. And of course, we don't document in the presence of a client. So we want to use this is a useful tool for help identifying communication patterns. Okay, so that processing recording form. So now, as a nurse assesses a new client, the nurse makes sure that the door remains open. Which type of communicating factors is this action? What do you think? The doors are open. So, of course, environmental factors may affect the communication, including physical factors, background noise, lack of privacy, uncomfortable accommodation, and social determinants. Now, again, you if somebody's out in the hallway keeping up a lot of noise, you're not going to be able to hear that client, especially that client is speaking softly. Then again, if this is personal and confidential information, they don't want everybody to hear it. So their environmental factors may be affected with this form of communication with the remains open. Now I want to say this: if you got a client that is dangerous, that's a threat to you or himself others, you definitely don't want to be in a closed environment with that client. You need some support there. So again, you got to assess the situation and the circumstances again also. So don't put yourself in harm's way either. Okay. So this is the lecture on therapeutic communication, and the last one that I'll talk about for today's lecture will be chapter 10. So I'm going to upload this one as well into the course. Thank you.